This is the AAOS Career Podcast, part of the Bone Beat Orthopedic Podcast channel. This monthly series features conversations on professional development and growth opportunities within the field of musculoskeletal healthcare.
Hi everyone, I'm Ellen Lutnick, Chair of the Resident Assembly Executive Committee, and this is the AAOS Career Podcast. This is my first time hosting, and before I dive in, I want to thank my predecessor, Dr. Rex Lutz. Dr. Lutz did a phenomenal job over the last 8 months, bringing up important topics on this podcast, and he really set the stage for me to take over as host, so thank you so much, Dr. Lutz. This is a compelling topic for my first episode and something that's near and dear to the hearts of all of the residents that are currently in training, like myself. Joining us today to discuss the pros and cons of early subspecialization and residency training is Dr. Doug Lundy. Dr. Lundy is a trauma surgeon at St. Luke's University Hospital in Bethlehem, Pennsylvania. He's also one of the editors for the AAOS Now, and he is also one of the hosts for the AAOS Now podcast. Dr. Lundy, welcome to the Career Podcast.
Thank you very much. I appreciate it.
Thanks for being with us. The question we're tackling today is a bit nuanced, talking about early subspecialization and whether or not it's helpful, whether or not it's harmful. I want to get started by talking about what that actually means, kind of your definition.
Right, so we talked about this. We actually had a symposium at the American Orthopaedic Association this year that talked about this, where we tried to kind of define the issue. And I think really what it is the focus of residents within their training to quickly gravitate, much more so than just an interest in a specialty, but really giving a disproportionate amount of their time and attention to it, either from an informal basis to where I like total joint arthroplasty, so if I got space, I'll jump in that room, to where I intentionally direct myself, or I have real rotations toward my subspecialty toward the latter half of my residency.
Yeah, and I think now with training, I mean, as medical students even are interested in orthopedic surgery, it's certainly an advantage to kind of identify early on where that interest lies. And so maybe we carry that with us into residency. Where is that balance between this is maybe a helpful early interest, or maybe you're narrowing your focus too much too early and missing out on other opportunities?
So there's so much to unpack on that. It really keeps going on and on how it goes. And my perspective is kind of nuanced because I was in private practice, large orthopedic private practice for over 20 years, where I hired at least 40 or 50 orthopedic surgeons in my old practice. And then being in academics for the last 4 years, I see it from the other spin on this. When I was on the board of the AAOS, the constant mantra was your certificate says orthopedic surgery. It doesn't say orthopedic trauma surgery. You can get the subspecialty certificates in hand surgery or sports medicine. But for most of us, our certificate says orthopedics. So if you're going to be certified in orthopedics, you shouldn't cone down into musculoskeletal oncology the first day of your second year of residency. That's, of course, an extreme example, but there's so much to that early subspecialization helps and hurts.
Yeah, so have you, in your experience, kind of looking at it from the bird's eye view with all of your experience, is there a certain problem that early subspecialization is trying to solve? Is it related, in your opinion, more to skill acquisition? Is it related more to preparedness for fellowship? Kind of what is this in response to? So
when I was co-president of my former group in Atlanta, it was very rare that we hired an orthopedic surgeon that had competency-based issues from a technical standpoint, whether they were capable of effectively doing an ACL reconstruction or nailing a femur or doing a spinal arthrodesis. That was rare that folks had that. It was generally other things. I think what it is, though, is what you get out of your fellowship is kind of what you start with and what you put into it. So if you're at a higher level of entering fellowship, I think you may be able to glean more from it, perhaps. So I think there's definite advantages to that. But a clear example, too, is a fair number of our residents, and I think residents across the country, are dead set, I'm going to do X, and then after they get into their PGY4 or late their PGY3 year, they're thinking, actually, I like Y better. Oh my gosh, is it too late for me to pivot? Do I really want to do that now that I've seen that on the deep side? I really do like this better. And I can't tell you how many folks I've met along the way that I'm absolutely going to do this, and the next thing you know, they're doing something completely different.
Yeah, so maybe we're limiting ourselves if we're identifying a choice too early without some more information, some more experience from the general side of things. That's a great point. I guess, so if a resident is thinking about their target subspecialty early on, and I think a lot of us do come in with some idea of what we might be interested in or certain mentors that we work with informing our decision, is there a way to navigate that without limiting ourselves?
Well, and you and I talked earlier, so I was the president of the OTA last year, and in my talk I put a quote up that I've thought a long time, is that you don't pick trauma surgery, she calls you. One of my chief residents a couple of years ago was torn between total joint arthroplasty and trauma, and he said, all right, I've got half the people are telling me to do one, half telling me, you break the tie, I guess I'm doing trauma. I said, no, you're doing joints. He's like, what? I said, trauma never called you. She never called you. You're a joint surgeon, be a joint surgeon. And he's very content doing that. I was just talking with another surgeon earlier today who clearly, their characteristics and their personality and everything really focuses, and the workload and the balance of a specific specialty is specifically what he is. So I think that if you listen carefully, you can like many different things, but there's one specialty many times that calls out to people saying, you can't live without me. Plus there's other parts to this, right? So if you go into oncology, other than really complex total joint reconstruction, you're pretty much doing oncology on a day in, day out basis, with rare exception. But there are other specialties, like sports medicine, for instance, where you have very elite sports medicine doctors who do nothing but left ACLs. But there's a lot of sports medicine doctors who have more of a general practice. So some specialties enable you to focus and be an expert on ACLs and shoulders, but I also fix hip fractures and do simple foot and ankle things and hands and things like that. And there are other specialties like perhaps oncology or maybe even pediatric orthopedics where you're doing that, and that's what you do.
Yeah, that's a great point. I think from a practice standpoint, even just further along in the residency process myself now, there is so much breadth to what's available as far as how you actually spend your days, even in trauma, right? I mean, it's not just being on call 24/7 anymore. There's people who solely take care of cold trauma or do locums and have a little bit more of a balance with that. So it is hard to anticipate kind of what you might get yourself into on the flip side, even a fellowship. So what might be some of the disadvantages then in spending less time in residency, building more of a breadth of surgical knowledge, being a little bit more of a generalist?
So, and this is a little bit, this sounds like Gnosticism, and I'm a little apologetic about saying this because this sounds a little like your father talking to you, but you actually learn so much about your future specialty from the other work that you do. So within trauma surgery, you learn very well how to handle injured soft tissue. So I feel that, I'm not dissing the other specialties, but I feel we are very good, maybe not better than them, but we are very good as trauma surgeons at handling injured soft tissue envelopes, because they'll come back and bite you fast if you don't. And whereas other specialties may be able to focus more on other aspects of the surgery. So I think that you pick up different things from different specialties and you carry that into there, and you can use perhaps those tips and tricks that you learned in any specialty you're in, arthroscopic surgery, adult recon, spine, peds, hand, whatever, and then toggle it into your future specialty. I think that helps a lot. And just remember also, we're board certified in orthopedics. Part 1 is a general exam. Part 1 is not specialized, shown on your specialty. Part 2, yeah, we can look at what you did, and if it's nothing but left ACLs, that's what we're looking at. But Part 1, you still have to answer all the questions. And it's more than just book knowledge, right? Because a lot of these scenarios, you could memorize all the answers, but to a certain degree, it does rely a little bit on your experience coming into it. And if you don't have experience in that area, you're a little bit out of water.
Yeah, definitely. You mentioned before that you've seen in the past residents who have maybe early on identified something and really gung-ho expressed that interest, and then later on in their training, maybe before fellowship, thought about pivoting. What advice have you given to residents in that situation when you've encountered that?
So the big things that I tell them point blank, and within the residency training, it's an easier part because you get to know these folks to a degree, and I think that a lot of us kind of know this is what you're supposed to do. You'll figure it out eventually, but we're not going to tell you. But everybody talking about you goes, they're actually a hand surgeon. I don't know what they're doing over there, but they're going to do hand. I think that you really need to listen for what specialty's calling you. And I know that sounds kind of esoteric, but it's that one thing that you can't live without. I've got to do replant surgery or microvascular surgery. I love time under a microscope. which I could never say that. But people that say that don't go into trauma. We're dealing with big bones, big things, big hammers. And so you can like trauma surgery, you can have a kick out of what we're doing here, but if you can live without that and you say, yeah, I can do trauma on the side, but my big thing is whatever, you need to do that. I think that looking at lifestyles, looking at compensation, looking at the medical liability climate, looking at all those things is far less important than the day in, day out, how it goes on that. Let me come back to trauma on that. So I've been doing trauma. I finished my fellowship in 1999, so that's 27 years now. And if I get called now at 2:30 in the morning about an impending compartment syndrome, I'm not gonna be able to go back to sleep. I'm not gonna be in a good mood when my feet hit the floor. As I'm popping my contact lenses and I'm still in a crummy mood, storm down the stairs, get in the car. Halfway to work, I'm start going, this is gonna be kind of cool. And then when I get to the hospital, especially when the residents are, I'm like, let me show you guys, this is gonna be cool, single incision fasciotomies. Y'all haven't seen this, this is gonna be great, let's do this. And then all of a sudden you're in it. That's when you know, all right, I did the right thing.
Yeah, absolutely. I think that's follow your gut, really, and maybe also listen to your mentors when they seem like they're steering you in a certain direction, because you've been around, you've seen a lot of trainees kind of come through, and maybe have identified certain personalities or habits or areas of interest, or you see your mentee light up about something.
And the lifestyle stuff has changed, right?
Yeah.
I mean, many of the things now has changed so much. I mean, when I started, the total joint replacement surgeons were like, you stay away from the ASC, do not breathe on it, keep your stuff far away. Now they own the surgery center. When I left Atlanta, we were doing anything we could to get our joint reconstruction folks in the ASCs to do their joints there. So things completely change. You're not gonna be able to predict that lifestyle and how things go from there. So do what you are called to do.
Yeah, that's great. I think great advice probably for any facet in your life. With early subspecialization, is there a possibility, this is maybe playing devil's advocate a bit, that residents who are really, really interested early on, or maybe have correctly identified that that's an area of interest and maybe they don't pivot, does that potentially make inequities within a program? Residents that maybe aren't expressing as much of an interest, not getting access to the more niche mentorship or, complex, rarer cases. Have you noticed that, or kind of how to navigate that space?
Sure, that could happen. We have one of our chief residents now. He was a physician's assistant prior to going to medical school, and he worked for a total joint recon surgeon. Came in first day, I'm going to be a total joint recon surgeon. Many of my folks knew him because he worked in the area. They're like, yeah, we know. I was like, oh, okay. And he's phenomenal at it. Now, he has spread himself across, but if there's an open joint room somewhere, that's where you're going to find him. And without question, he has seen things and done things that other folks would not have on the other hand. However, who says your mentors come from your specialty? You're going to miss orthopedic surgeons are not that far apart, and many times the mentorship or the relationship aspects that you get come from people in other specialties. I know within the Leadership Fellows program, within the Academy, many of the best mentors I met, and to this day, who are some of my closest friends, are not trauma surgeons. Trauma surgery is great. I have a lot of great friends and great mentors in trauma, but I've made friends across the platform because I didn't focus just on the Trauma Association, but outside of that as well. So I think that if you specialize too early, you could miss that. So the folks that are more measured at going into it, they'll get enough. You're gonna get it in your fellowship. So maybe you come into fellowship a little better advanced or whatever, but if you're focusing hard in those 60 months of your residency, you may be a little bit better at arthroscopic surgery or hand surgery or trauma or spine, or bring that into it to the person that just focused on, foot and ankle from day one, and that's all they are, is a foot and ankle surgeon. Yeah,
that's a really good, just from a mentorship standpoint, I think that's a really good point. Some of my most longitudinal mentors aren't necessarily the trauma faculty that I work with closely now. We have a hand surgeon in our institution I've known since I was 19. And if we can, make a shameless plug for the Academy for the annual meeting, you get to meet those mentors again here in this space, because they are maybe not at your subspecialty meetings later on, but it's really kind of a melting pot for all of that.
And this is the place where you're going to run into those folks. We talked about that at the Board of Specialty Society meetings this morning. Chick Yates, who's the chair of the Board of Specialty Society meetings, identified that this is where you see your friends outside your little clique group.
Yeah, absolutely. I guess maybe to hopefully bust some myths or reaffirm some anxieties from someone who's going through the fellowship application process right now. Are fellowships looking for people that are, really just well-rounded generalists, or are they looking more for residents that have, maybe can talk more on their subspecialization within the residency program and how they've sought out those additional cases or extra experiences?
It's a fascinating question. So I think it kind of depends on the culture and the place you're going. I know a lot of friends in the trauma fellowship business, and I've talked to a bunch of them about those things. And what they want is very similar to what I want, which is a teachable spirit. I want the resident who's going to come in, especially the PG 4s and 5s that come in going, I know how to do this case, then the teacher doesn't appear. And sometimes my PA is going, why don't you just tell them what we'd already be done if you were involved? I'm like, they think they can do it. Let's let them swim. As opposed to the chiefs, I've had one chief specifically look at me and said, I am going to be on my own after my fellowship. Show me how you would do it. I was like, wow, okay. And so I think it's that teachable spirit as you come into fellowship, regardless of what you've done ahead of time, of saying how, show me what can I learn here, as opposed to look what I've already done and all that. I remember when I started my fellowship, I came home one day and my wife looked at me and she says, what's wrong? And I said, I realized that specifically the injury we were talking about, everything I learned in my residency about that injury was wrong, that the guys at Vanderbilt have figured this out. Nothing against my residency training or that, but the guys at Nashville were so good at that, and if I had come in with a different attitude, they would have beat it into me, but it was a lot better to come with open hands going, please let me learn how y'all do it here.
Yeah, absolutely. I know even on my interview experience this year, there's been a lot of talk about, we want to give you more tools to add to your tool bucket. Even if your residency program's doing a great job with this, here's one more backup plan C, way to approach this problem if something goes wrong, if there's a certain body habitus or injury pattern that you need to address in some type of way. So maybe less about the clinical knowledge you come into fellowship with and knowing how you need to learn as a learner.
And I don't put a cap on what I teach my residents. If they're interested, we'll go as high up and as deep as they want to go. But I can almost call them out sometimes, okay, we're leaving residency and entering fellowship. Or we're leaving fellowship and now entering the true world of mastery on this. Let me show you the true deepest areas of this for the ones that are interested. And a lot of these folks, are not necessarily going to do that, which is an interesting part we should probably get into is if you specialize too much, are you hurting yourself in your future job?
Yeah, fair point. I mean, even kind of like you mentioned before, maybe subspecialties beyond trauma that you need to take some call or you need to be able to have a little bit more of a general practice, especially as you're first starting out. It is becoming more and more common now, at least in talking to other people on the trail and just seeing it, for people to do more than one fellowship. How does that change how you approach education and residency, if that's something that's in the cards for you?
Wow, I'm not sure it changes what you do in residency per se so much. Those folks, they're a very interesting group because if they are exactly what you're looking for, then they're invaluable. If they're not exactly what you're looking for, sometimes the dual fellowship can almost push as a prospective employer, like, I don't know how I'm going to make this person happy because I don't have that niche. I see what they're looking for, but I have this. And is this going to be good enough, or are you going to do this for a while and then leave me when you find the right one? But from a residency standpoint, I don't know if that changes it very much. I think that you really would just target that on and just, if anything, it helps you broaden their education a little bit.
Yeah, that makes sense. So what, if you are thinking about focusing on a certain subspecialty like we all do at some point in time for the most part, when is that kind of sweet spot for residents? Is it, right as you're starting the fellowship application process? Is it during your PGY2 year? Is there something you can do even after you match into fellowship to kind of help to aid that education process along?
Yeah, I think that it's probably good sometime in your 3 year, I think, is what I perceive as the sweet spot. I think if you pick it too early, you don't really have exposure to everything yet or as much as you need. A lot of times the pediatric rotations are late in your 3rd year. So if you pick adult recon in January and then you're on pediatrics in April, you're like, gosh, this is what I should have been doing. Now I've got to pivot. So it's good to stay very plastic and flexible up until the match comes open and you've got to start doing those things. My big concern, of course, is the folks that pick X and then after they're well down the match process, wish they had done Y. That gets a little sticky. Ironically, and sometimes in the match, the fellowship match, Scott Steinman will tell us there are people that will put 2 specialties in there. I think that's fascinating about how somebody would say, I'll do X or Y. It's like, okay. And sometimes X and Y are light years apart in my mind of how those would be related. That's not to say that you can't do that, and there's nothing you can't do a second fellowship after that. Brown has a very interesting scenario where they do that 6th year as a trauma fellow, where they finish a residency at 5 years, and then the whole class stays on for another year as a trauma fellow, and then a lot of them pivot off. I hired 2 guys from Brown, one's hand, one's sports medicine. Both are excellent trauma surgeons because they did an extra year of trauma surgery. I think that gave them a little bit more leeway. It was another year of residency, but it gave them, or training rather, gave them another year of flexibility into that. But that's of course the big thing is the tremendous pressure that y'all face. Going, man, I've got to get this right, or I could potentially not necessarily burn a year of my life, but add another year of training in if I found that it's actually a different one that I selected.
Yeah, that's a great point. And it's interesting you mentioned that about Brown. We have a hand surgeon at our institution who came from their residency program, and hand is its own level of trauma call, but
right.
I think that extra year, she's a great teacher and a great instructor in the operating room, and I don't know if that's just her or maybe that just gave her that extra layer of comfort with instructing residents to walk through a case or to let us struggle in a way that's safe.
I see that in both of the ones that I have, and they do have that, I think, an extra sense of confidence and competence just from that year of, it's like an extra fellowship, where they had more autonomy but not complete. The safety net was not completely removed.
Yeah, so maybe one advantage to considering that 2 fellowship track is just one more layer to fall back on or to pull from.
However, I gotta say though, like when I was at Resurgence, that if I wasn't looking for you, I would go, my immediate thought was, am I gonna make this person happy? And at my old group, my goal was for you to come in and leave me 35 years later. I didn't want you to leave a second before your 35th year. I wanted you to stay at the group, Don't come and leave. That's cost so much time, money, and effort and investment in the group to get you there. We want you to stay. And that second fellowship, I'm almost like, if I don't have that sweet spot for you, you're almost apologizing. Well, I can offer you sports, but I can't really offer you, whatever that other part is.
Yeah, definitely trade-offs then with any of that. If you could change something about residency training to better prepare surgeons for the reality of practicing today, whether or not it's subspecialization or something else kind of adjacent to that topic, what would you recommend?
And I can't answer this one because I looked at that question and I kept thinking about it, and we probably shouldn't put this part in, but when I was on, or you could put it in, this would make it really legit and honest. When I was on the AAOS board, the directors on the board had very strong ideas. I was the only private practice person on the board. So they had very strong ideas about education and who am I going to be to correct them? I'm like, whoa, okay, you guys and women are the experts. But to watch the way they do it, and they could certainly pick it out. But from a large context, I'm very satisfied with the exposure that our residents get and the training they have. I think that the ROC is amazing. Really gets them, they're not memorizing ortho bullets, they're really getting into the deep end there. The exposure to just being a doctor, where we're not going to the OR, not just focusing on upper reduction, internal fixation, or all the cool stuff you and I do, but it's, you got a patient on the floor who's not happy because their discharge was held up. Okay, go fix it, and you got to know you got to have that emotional intelligence to be able to fix that by being in that before, realizing how you carry yourself in the room, realizing when somebody needs to go on a rant. You smile, close your hands, and you listen. You don't cut them off and roll your eyes and look at your cell phone. And the only way to learn that is to get in that environment where you get the repetitions and do it wrong. And we're like, okay, not doing that again. That just blew up in my face, and the senior resident or the attending walks in going, oh my gosh, just watch me. And they may not get it right, but my point is that I think that those things are so important. But the system, at least at our place and in my perception on many of the places that I've talked to, is getting it right. So my colleagues on the AAOS board probably could point out these things. I'm aware of the competency-based programs that we talked about extensively when I was on the board. But in my perception, it runs pretty darn good. And I work around the world. I work with residents from around the world, mostly in the developed world, and especially in East Africa. And our product is so good relative to a lot of the systems that are used in other places.
It's very encouraging, honestly. Like, as an honest opinion, truly. I think as a trainee, it's easy to think about your training as like, can I do this case? Can I maybe get a little bit more nuance? Can I recommend the correct treatment for this patient? Should I operate on this person? Yes or no? Do they have a surgical problem? Are they going to be someone who's going to do better with surgery? The answer isn't always the same for people. I think especially for our junior residents, we don't always give enough credit, and even myself going through that process, an intern and a PGY2, we don't give enough credit for just how hard it is to learn how to navigate the healthcare system and have that conversation with a patient who is not happy or hungry, angry, tired, had other plans for their day, and now is seeing you as the intern covered in plaster at 2 o'clock in the morning, and they're like, why am I here? What are you doing? Are you even old enough to be my doctor? But it is, I mean, the whole process of just becoming a competent physician is so much bigger and deeper than just being a surgeon. And if anything, that's kind of the finishing touches on your training rather than, the whole of it. Do you have any advice for, especially maybe more junior residents who might feel like they're being left behind because they see their co-residents identifying subspecialties early on, kind of locking into those and maybe feeling like they are not keeping the same pace as their co-residents?
So I tell them that they're actually, especially at the PGY 1, 2, and early in 3 year, you're actually in the better position. Because number one, you're more open-minded, you're watching. Because a lot of them, it is so funny, I don't know what it is about hand, but a lot of them get to the hand rotation and go, I want to be adult recon, I want to be trauma, I want to be spine. They get on hand, they go, nope, it's hand. I'm like, what happened in there? What did they do to you? We like to pick on hand surgeons, but it's funny how they suddenly pivot and they pop out the other side and they're like, that's what I'm doing. So if you made up your mind too early, you're not going in with that open mind, or you didn't want to hear because I don't want to be a hand surgeon, then you're like, no, that's actually what I should have done. So I think that's an important part. The other part that I iterate over and over to our residents is, although you don't have to be board certified to pre-practice in America, it is really hard to. And if we want to be proud of our residents coming through there, and it's harder to be proud of you if you can't pass part 1. And you can't take part 2 until you pass part 1. And so part 1 is a general exam. And if you're focused on trauma surgery from day 1 of orthopedic surgery, and the sports stuff comes up and you're like, ACL, whatever, what do I care about that for? Then you're missing out on the education that you need, because we are board certified in orthopedic surgery, and we should become competent orthopedic surgeons before we become trauma, hand, foot, and ankle adult recon.
Yeah, absolutely. What would you say, if you had a takeaway, what's one skill that every orthopedic surgery resident really needs, regardless of their subspecialty?
Well, that's kind of funny on that. I think the bottom line is we have to be teachable. Like I said, when I was earlier on, it was very, very rare at Resurgence in Atlanta or at St. Luke's in Bethlehem that I have to deal with a doctor on surgical competency issues. Sometimes indications, sometimes we let our indications get a little sloppy, but it's rare that I have to deal with that core issue. The residents aren't going to like what I'm fixing to say, but the number one thing graduating residents I hear when they come back is, I wish I'd spent more time in clinic. I know. But that they say the clinic is where they learned how to indicate people, learned how to nuance those conversations, learned how to do those things. For you and me, clinic ends up being the ER, but we also got to see these folks in clinic afterwards, so that goes there as well. I think the teachable spirit and the art of doing what we do, of knowing what to say when and how to nuance that, and even after you've been doing it for years, you walk out there and go, I did not handle that as well as I could have, because there is absolutely, as trauma surgeons, I'll use that specifically because that's what you and I do, there is nothing more gratifying than walking into a total mess and you look at it and you see through the mess, you see the clarity, you see where this is going, the family's shattered, nobody knows what's going on, and you're like, I got this. We got this. This is what we're gonna do, it's gonna work. Follow me, we got this, everything's okay. And you watch the whole room settle down and everything, and all of a sudden people are looking at you like, man, I gotta deliver this now. But you know you can. And you go back there and you do it and you come out and there's nothing better than you walk out in the waiting room. They're all tense, you're like, remember everything we talked about? Exactly as planned, nothing surprising, they're doing well, let me tell you what I did. And you watch the whole thing come down on that. That's what pumps you up and keeps you going day after day doing that. And although that was a very trauma-centric explanation, you could say the same thing in any other specialties, the 9 specialties that we have: shoulder and elbow, foot and ankle, adult recon spine. It all peds, it all does the same thing.
Yeah, and not to just keep talking about trauma versus our other subspecialties, but I do think that is a lot of our, as a resident, that is a lot of your first experience in that set and setting where people are looking to you to be the voice in the room from, representing your team and your department. We all hold the pager, we all go into the emergency room. I think I definitely do, and I can probably maybe speak for other trainees, but the first time you walk into a trauma bay and have everyone in the room turn and look at you and be glad that you're there because they've worked with you enough and know, and it's not just the patient, right, who has this problem, it's, the staff around you who know, okay,
right.
Orthopedics is here now. And you really get that first sense of knowing what you're doing and being in control of a situation that is relatively uncontrollable in that setting as a trainee, which is a very powerful thing, I think.
And I've seen that with the sports docs on the field.
Absolutely.
I covered the games because I had to, but man, when they could do something on the field, they were in heaven. They got just, you could see them pop up of getting athletes back to it. And the adult recon surgeons on helping, they're so proud that somebody's knee is now out of varus, that the person can walk without aid, has a good timed up and go test and all that. And you watch these people do the hand surgeons with all the intricate motions of the hands and the things they're able to do there and the pain they're able to relieve. It calls each person individually, and that feedback that they get from that, that's what people need to be looking for. When they get home, residents, when they get home at night and they're looking at the different specialties, don't look at the workload, do not look at the compensation. That's gonna change. So that's just immaterial anyway. You're in the wrong business if you're doing that. Look for that thing that you can't live without. I've got to correct varus knees, go into adult recon. I've got to, decompress radiculopathy, go into spine.
Yeah, I was going to ask you what our final takeaway was going to be from our podcast, but I think that's it.
That's it.
The thing
She's
you can't live
calling
without.
You just got to hear what she says.
I love that. Thank you so much for joining us,
Thank you so much.
Dr.
I appreciate
Lundy.
it. Yes, ma'am. Thank you.
Thank you for listening to this episode of the AAOS Career Podcast, part of the Bone Beat Orthopedic Podcast channel. Production and editing provided by MK Quinn Media. Check out the video version of the podcast on the AAOS Career Podcast YouTube channel. To hear other conversations on professional development, please visit aaos.org/thebonebeat.